Hello everyone. For those of you who haven't been able to attend any of the other sessions so far, my name is Rebecca Chaudhry. I'm a physician, one of the infectious disease fellows at Montefiore, working closely with the antimicrobial stewardship program. Thanks very much for joining in this, the final session of our abbreviated antimicrobial stewardship program for skilled nursing facilities. Today, we're going to be talking about best practices for the diagnosis and treatment of cellulitis, soft tissue and wound infections in skilled nursing facility residents. So just some brief disclaimers before we get started. Most of the materials contained in this presentation are taken from the AHRQ, but shouldn't be taken as any sort of official policy position of the AHRQ or the US Department of Health and Human Services. And all of the information in this presentation is intended to supplement your own clinical judgment. It's not intended to be some sort of hard guideline overriding your own decision-making when it comes to taking care of the patient who's right in front of you. So to lay out some of our objectives for today, we are going to talk about the approach to diagnosing cellulitis and skin abscesses and the differences between the two. We're going to talk about the microbiology of cellulitis and skin abscesses and how this informs our empiric antibiotic choices. We'll talk about different treatment options for cellulitis and skin abscesses, and about opportunities to de-escalate our antibiotic therapy as patients improve and as we get culture data back. We'll talk about reasonable duration of antibiotic therapy for cellulitis and other soft tissue infections. At the end of the presentation, we'll also talk about some risk factors and prevention strategies for pressure injuries and the role of antibiotics in the management of stage 4 pressure ulcers and associated infections. Especially during the first part of our talk today, we're going to structure it around this 4 moments of antibiotic decision-making framework used by the AHRQ. You may remember it from some of the earlier presentations if you were able to join. This is just the idea that as we are treating a patient with antibiotic therapy, there are 4 decision points when we need to evaluate or reevaluate our use of antibiotics. Decision point number 1 is whether or not the patient actually has an infection that requires antibiotic treatment versus a non-infectious condition mimicking an infection. There are many that can mimic a soft tissue infection. We'll talk more about that soon. Decision point number 2 is whether we've ordered appropriate cultures or other diagnostic tests before we start antibiotics. And once we have our testing done, what antibiotics we should start. Decision point number 3 is about when we can think about stopping antibiotics, narrowing antibiotics, or potentially switching from IV to oral antibiotics. And decision point number 4 is what duration of antibiotic therapy is going to be appropriate for this particular patient and their particular diagnosis. For decision point number 1, does my infection have, or does my patient have an infection at all? Let's start with a case of Harry. So this is a 73-year-old gentleman who lives at your facility. He does have some chronic medical problems, chronic kidney disease, peripheral artery disease, CHF, and he is also a current everyday smoker, about half a pack of cigarettes per day. Over the past couple of years, he's been hospitalized multiple times for volume overload, although he's doing fairly well right now. And when you come into work in the morning, you hear a report from the overnight team that Harry's legs are looking swollen and red today. So when you go to see Harry, you check his vital signs, which are at the right. His temperature is 98.2, heart rate of 71, blood pressure of 108/67 with a respiratory rate of 14. When you go to talk with him, he's just sitting in an armchair in his room watching TV, seems perfectly happy and comfortable. You do notice that he has pitting edema to both of his knees. And the skin on his legs looks something like this in the picture below. It's very shiny and bumpy, flaky in places. It is erythematous kind of everywhere. And when you touch it, the skin is maybe a little warm, but it's not tender at all. So at this point, a question you might be asking yourself is, does Harry have cellulitis or not? What do you think? Give a couple seconds for people to answer. Okay, so we have some votes for yes, most votes for yes, a vote for no. It can be very tricky in a patient like Harry to tell the difference. So let's talk about some of the ways you could maybe differentiate cellulitis from some non-infectious mimickers. So cellulitis typically is going to present with usually unilateral redness, warmth, tenderness, and swelling. It will be typically quite rapid in onset. We're talking a matter of days as compared to a matter of weeks. You may also see some systemic signs of infection, fever in up to 70% of patients, but by no means all patients with cellulitis may have a fever. Certain laboratory abnormalities you may also see, like elevated inflammatory markers or leukocytosis. These are common, but not always present. Cellulitis is often associated with some sort of skin surface disruption, like recent trauma to the skin, or other infections like tinea pedis or athlete's foot. Any sort of ulcer or a prior surgical procedure like a saphenous venectomy, or a resident who has chronically impaired venous or lymphatic drainage due to lymphadenopathy or a lymphatic injury, or due to a condition like chronic heart failure is also at increased risk for cellulitis. But there are a lot of non-infectious syndromes that can really look like cellulitis in one way or another. This sort of misdiagnosis is very, very common. In a study of 145 patients who were hospitalized for cellulitis, about 28% of them actually did not have an infection. Instead, they had one of these diagnoses below. So venous stasis dermatitis is by far and away the most common. I would say that this is likely what Harry has. We'll talk more about that. But some of the other non-infectious syndromes you might see masquerading as cellulitis include trauma-related inflammation. That alone can cause erythema and swelling. DVT can sometimes mimic cellulitis, and it can sometimes be unilateral. Non-specific dermatitis, and which is just kind of a catch-all term, and thrombophlebitis. So these are all conditions that will not respond to antibiotics, but can easily be mistaken for a bacterial infection. So venous stasis dermatitis looks like the picture you see at the right, and also looks like that picture I showed you in the case of Harry. So this is a usually bilateral condition that is going to be present for a long period of time, but you may see changes, more edema, more redness, kind of depending on the patient's current volume state. So you will see these chronic hyperpigmentation changes. The skin is thick, it's red, it's often bumpy or flaky. And in a patient who has really severe edema, you may also see some blisters with serous drainage, like you can see this patient likely had. There can be itchiness and scaling, and edema can sometimes also be painful, but it shouldn't be exquisitely painful to the touch in the same way that cellulitis often is. As a key factor, a resident with venous stasis dermatitis should not have a fever or significant leukocytosis. And so this condition is going to be treated with elevation, compression, sometimes topical steroids if the itchiness is very distressing, but typically supportive care. Antibiotics are not going to make much improvement here. Lymphedema is another condition that you may see mimicking cellulitis. Like cellulitis, it is usually unilateral, which can make it challenging to differentiate. The extremity, like you see here, is going to be diffusely edematous, and erythema, this picture is not, but if there is redness, it will also be very diffuse, and it should be non-tender or very minimally tender. There shouldn't be any associated systemic signs like fever, leukocytosis, etc. Peripheral artery disease, another condition Harry has, can present with a condition known as dependent rubor. So this is redness at an extremity, typically a leg, that goes away once the leg is elevated. As you can see at the right, leg is down, it's kind of diffusely pink, and then once you elevate, the redness goes away. So these patients can have claudication, that is pain due to poor circulation, especially with physical activity. But you shouldn't have any particular warmth or edema in the affected extremity. So some of the other conditions you can see mimicking cellulitis include contact dermatitis. So this is going to be a very local area of irritation on the skin, where that skin has come in contact with whatever the allergen is, like a bandage or an EKG sticker, for example. So if you see something like this, it's important to ask the resident about or review their chart for any potential exposures that could have provoked the allergic reaction. DVTs can also sometimes look like cellulitis because they're usually unilateral. They can cause swelling, redness, and pain. But you shouldn't see the very prominent erythema involving the skin the way that you would expect with cellulitis. And gout, which is a crystal arthritis, deposition of uric acid crystals in a joint, will cause a lot of intense pain, redness, and swelling localized at the joint that's infected, very often a toe. And it can even cause some inflammation in the skin close to that joint. But it will really be joint focused, different from cellulitis. And so this is something to consider, particularly if you know that a patient has a history of this condition. So moving on to decision-making point number 2, whether we've ordered our appropriate tests, and once we've done that, what empiric therapy we should start. Going back to the case of Harry, so after, reviewing his chart and examining him, you think that maybe this could be venous stasis dermatitis rather than cellulitis. And so you decide at first to just treat him supportively, and when you elevate his legs and give him some compression stockings and monitor his salt intake, his legs do seem to get better at first. But then after about a week, he scrapes his right shin against his walker while he's walking around. And 3 days later, you hear that he's having new, very severe pain in his leg. So you go to see him, and you find that now his temperature is 99.8 with a heart rate of 87, blood pressure of 124/71, and a respiratory rate of 16. Now he looks very uncomfortable. He tells you that he's really in a lot of pain. And you see that his right shin is now much more red compared to the left. The redness extends kind of all the way down his leg, but there is also a focal area of swelling in his right upper shin, which is especially warm, hot, and very tender to the touch. And you see that in the middle of that swollen area, there is a little cut with a small amount of pus draining from it. So at this point, what would you like to do for Harry? Do you want to send some blood cultures, send a wound culture, go ahead and start him on some antibiotics with vancomycin and ceftriaxone, or should we send him to the emergency room? Okay, I'll give it just a couple more seconds. Okay, so we have a vote for sendo wound culture, and we have a vote for starting vancomycin and ceftriaxone. So there are certain circumstances where sending blood cultures and wound cultures before starting antibiotics are appropriate. So let's talk a little bit more about what those situations would be. So these are, sorry, some additional information that I forgot to give you. But basically, we can just move on. So in the majority of cases of cellulitis, blood cultures will be negative. They're positive less than 5% of the time. And so we don't typically include them as part of our routine diagnostic process. However, if you have a patient who is very severely ill, or who is immunocompromised in some way, maybe they have a cancer that they're getting treated for, maybe they have some sort of organ transplant, then these are conditions who are more likely to actually have bacteremia associated with cellulitis. If you have a resident like Harry, who actually has an area of their infection that's draining pus, it can be helpful to obtain a culture from that pus that's draining. So ideally, what should be done is an incision and drainage of the purulent area, and using a small syringe, collect a sample of the fluid to send it directly to the lab. In a situation like this, you could also do something like thoroughly clean the surrounding skin, and then use a swab to collect that pus. But you should just bear in mind that the swab is not as quite a good quality of sample. It might not be as diagnostically helpful as a fresh pus sample from an IND. So this is a good point to talk about some of the differences between purulent and non-purulent cellulitis. That is to say, cellulitis where there's pus and cellulitis where there's not. You can see a picture of non-purulent cellulitis here on the left. It is this sort of diffuse, smooth, uniform erythema with this nicely defined border here. We see no open wounds, no areas that are draining. As opposed to purulent cellulitis we see here on the right, where there is this open lesion draining pus with redness and swelling located around it. So this distinction is important because these types of cellulitis are caused by different types of bacteria. There's a lot of information on this slide, but just to highlight a few things. So your non-purulent cellulitis, this kind of cellulitis, is going to be caused by and large by beta hemolytic strep, particularly group A strep. And so the treatment for non-purulent cellulitis targeted towards strep is going to be largely penicillin or amoxicillin, or drugs that are closely related to penicillin, like cefazolin and cephalexin, first generation cephalosporins, or things like unicin and amoxicillin, or unicin and augmentin. As opposed to purulent cellulitis, where you have a wound that is actually containing or draining pus. This type of cellulitis is typically caused by Staph aureus, and in particular is often caused by methicillin-resistant Staph aureus, or MRSA. When you have purulent cellulitis, it is very important to drain it, because relieving that pus will really be important for the antibiotics to work effectively. Sometimes you may even need to use an ultrasound to make sure that you've really drained out all the pocket of abscess. And so when you're treating this type of infection, it's important that you cover empirically for MRSA, either with something like vancomycin in a very severe case, or with an oral antibiotic like trimethoprim sulfamethoxazole, aka Bactrim, or doxycycline, which also has very good activity against MRSA. Because, as you can see on this slide, so much of our treatment, particularly for non-purulent cellulitis, is going to be with penicillin or antibiotics that are closely related to penicillin. When you're treating cellulitis, you're probably going to encounter a resident with a penicillin allergy and have to make a decision about the best antibiotic to give them. So just some reminders about penicillin allergies, or quote unquote allergies. These are reported extremely commonly by up to 10% of patients in the United States. But when you actually challenge them with a skin test, 9 out of 10 patients who report they have a penicillin allergy are not actually allergic, or at least aren't allergic at the time they're tested. This is because for 80% of patients who have a true IgE-mediated allergy, including something like hives, after about 10 years or so, this allergy will go away. So even a resident who had a true penicillin allergy as a small child might not be allergic to penicillin anymore now that they're 70, 80 years old. So when you're talking to a resident who has a chart diagnosis of a penicillin allergy, it's very important to ask them what their reaction was. You're going to think very differently if it was nausea, which is just an intolerance, not even truly an allergy, versus something like hives, which is a true allergic reaction. You want to ask when their reaction was, because if it's a long time ago, remember, it's very likely that the allergy is actually gone now. And you want to ask if they've ever taken a similar antibiotic. It's helpful to throw out some specific names, like, have you taken amoxicillin? Have you taken Keflex? This can, help you get a sense as to how active their allergy might be. And just remember that cephalosporins like Keflex, like Ceftonir, have very low cross-reactivity with penicillin, less than 5%. So unless your patient has a very severe penicillin allergy, it's very likely that you could treat them with a penicillin-related antibiotic and they'll do just fine. So just to differentiate a little bit between skin abscesses and cellulitis. So an abscess is this pocket of pus here, which may or may not have this cellulitis, this area of warmth and redness around it. So when you have a resident with an abscess, the mainstay of treatment is going to be just to drain the pus. And for some folks with an abscess, antibiotics might not even be necessary. However, particularly for those who have a large abscess, there is some evidence, as in this study of outpatients with abscesses greater than 2 centimeters in diameter, that giving an antibiotic can help increase their rate of cure. But it's just important to note that there are always antibiotic associated adverse events. And so this needs to be sort of a risk-benefit discussion with your patient and considering their own particular risk factors for having some sort of adverse antibiotic-related interaction. And if you have a resident who has systemic signs and symptoms like fever or an elevated white blood cell count, or who has some sort of underlying chronic condition that weakens their immune system, or who's very elderly, these are all residents who would definitely need to be treated with antibiotics in addition to drainage. Sometimes you may encounter that the abscess is not in a place where it can easily be drained, or that the pus is reaccumulating after drainage. These are also, reasons to add on antibiotics, or in a case where the surrounding cellulitis is very extensive. And just a quick note, as you saw on my slide a few slides ago, so the majority of bacteria that cause cellulitis are going to be your gram-positive bacteria like staph and strep. Gram-negatives are very rarely the cause of either purulent or non-purulent cellulitis. Even in diabetics, there's sort of a common thought that they need to be treated with gram-negative coverage. But in the majority of uncomplicated cellulitis, even in diabetic patients, you're still worried about staph and strep. One exception would be if it's an infection associated with a chronic ulcer, particularly an ulcer that your resident has been treated with antibiotics many times before. And of course, if the resident is extremely sick, or if they have some sort of chronic underlying medical condition that weakens their immune system, or if they have an infection in the perirectal area or the groin or genital area where they're more likely to be gram-negative bacteria on the skin, these might be reasons why you might want to treat for gram-negative bacteria up front as well. It's also very important to keep in mind that antibiotics are only one part of the treatment for cellulitis. Anything that is going to reduce edema in that area or help damaged skin heal is going to be very helpful and very important. So if this is cellulitis in a leg with a lot of edema, you're going to want to elevate that affected extremity. If the resident has a condition like tinea pedis that damages their skin barrier, it's important to assess and treat for that. And any other treatments they need for the management of venous stasis disease or lymphedema, like compression garments, will also be very helpful in treating your patient with cellulitis. So moving on to decision point number 3, when can we stop antibiotics? When can we narrow therapy and switch from IV to PO? So with Harry, you do try to drain out some of the pus from his leg. You don't give very much, but enough to send for a culture, which does end up growing MRSA. Because his cellulitis looked pretty bad, you were worried, and so you decided to go ahead and start him on vancomycin. When you go to see him again 3 days later, he says his pain is much better, and there's no pus draining from that cut anymore, but you do see that his right shin still looks fairly red. Now he tells you that his IV site is getting a little uncomfortable. When you look at it, it doesn't look infected, but he still tells you that, he wants it out. So at this point, what would you want to do with Harry's antibiotics? Would you want to keep him on vancomycin, switch him to daptomycin, add some gram-negative coverage with cefepime, or switch him to an oral antibiotic? Okay, great. We have some votes for switch to an oral antibiotic. I agree 100%. So it's really important to note that an increase or lack of change in the margin of redness is not necessarily an indication of antibiotic failure, particularly early on in the treatment of cellulitis. Toxins that are produced by dead or dying bacteria can cause a lot of extensive local inflammation, even though the antibiotics are actually working well. And so if you see that redness is not receding, or if it's even spreading, that's not necessarily a bad thing, although you would expect to see that the erythema should become less intense over time. And those systemic symptoms like fever should be improving after 48 to 72 hours, if the patient is receiving correct antibiotics. So these graphs are from a series looking at the natural history of outpatient cellulitis, being treated with antibiotics. And this is just to illustrate that after a day of antibiotics, less 50% or so of patients may not have any improvement yet in their redness or the inflammation at the site of infection. So this is not necessarily cause for concern. It's really once you get to day 3 that you should be seeing, by that point in time, some significant improvement. So most patients who are started on IV antibiotic therapy or started on broad spectrum antibiotic therapy can typically be switched to oral or narrowed after about 3 days of treatment. If you've started treatment with an antibiotic that includes gram-negative coverage, after 3 days is a good time to narrow that, to stop that, unless you have a culture or something else giving you evidence of a gram-negative infection. And if you started treatment with vancomycin or another IV antibiotic, after about 3 days or so, you should be thinking about switching to an oral regimen, choosing an antibiotic based on the type of cellulitis they have. Again, non-purulent cellulitis, you're going to be thinking strep. You're going to think a beta-lactam like amoxicillin or cephalexin. Purulent cellulitis, you're going to be thinking MRSA. You're going to want to think something like Bactrim or doxycycline. So decision-making point number 4, about what duration of antibiotics we should use. About how long do you think Harry is going to need antibiotics? About 1 to 3 days, aka stop antibiotics now. More like 5 to 7 days, or 10 to 14 days. Okay, so we have some votes for 5 to 7, and we have some votes for 10 to 14. So this is going to depend a little bit on your individual patient and their individual risk factors, but generally speaking, about 5 to 7 days of antibiotics is going to be sufficient for most patients. So in a randomized control trial, looking at patients who had uncomplicated cellulitis, so no sepsis, no bacteremia, no diabetic foot infections, the patients received either 5 days of antibiotics followed by placebo, or 5 days of antibiotics followed by 5 more days, so 10 days in total. And in this study, they found that 98% of patients were treated successfully, meaning resolution of infection by day 14 and no recurrence by day 28. So even with as little as 5 days of antibiotics, these patients with uncomplicated cellulitis did very well, and there was no additional benefit to extending it out to 10 days. So of course, this is going to depend a little bit on your own individual patient and their degree of clinical improvement. But once you get to day 7 or so, if they really don't seem to be improving, that might be a time to go a little bit back to your diagnostic testing to make sure that there's not something that's been overlooked or missed. But just to sort of sum up some take-home messages from the first part of our talk, when you are concerned that a resident may have cellulitis, it's really important to make the right diagnosis. Remember, particularly in an older or chronically ill resident population, there are a lot of non-infectious conditions that can look a lot like cellulitis, and that can be easily mistaken for it. When you've made a diagnosis of cellulitis, it's important to distinguish between non-purulent and purulent cellulitis because the type of bacteria is different and the treatment is different, both in terms of the need for drainage potentially and in the types of antibiotics you're going to want to use. You should expect to see patients improving by about day 3 of antibiotics, but you don't expect to see a complete resolution of the redness. If they're otherwise clinically improving, that's not necessarily an indication that your antibiotics have failed. And 5 to 7 day courses of antibiotics combined with those non-antibiotic treatment things like elevating the extremity, making sure we're treating venous stasis edema, etc., will typically work for cellulitis in most cases. And clearly, there are many opportunities here for us to improve our empiric antibiotic therapy and our duration of treatment for cellulitis and skin and soft tissue infections. So I'm going to move on now to talking a little bit about pressure injuries and pressure injury associated infections. So here we're talking about localized injury to the skin and sometimes underlying soft tissue that typically occurs over a bony prominence. So there are different staging classifications depending on the degree of skin and soft tissue damage. And there are also unstageable pressure injuries where the degree of tissue loss can't be seen because of some overlying slough or eschar. So just to show some examples from the National Pressure Injury Advisory Council, here we see normal skin, stage 1, where there is erythema, there's damage occurring, but we don't actually see any defect in the skin. Stage 2, where the wound actually erodes into the dermis, the deeper layer of skin. And then stage 3, where we have a wound going all the way into the fat layer underneath the skin. Stage 4, where we're going all the way down to deep tissues like muscle and tendons and even to the bone in some cases. And then an example of an unstageable ulcer where there's eschar. Good to note that, if you have a resident with an unstageable ulcer that is stable in appearance, it's not edematous, it's not tender, It's not recommended or necessary to on-roof an eschar just for staging purposes. Better to leave it alone, which is going to have a lower risk of precipitating an infection. So there are many different factors that increase the risk of developing a pressure injury, including patient factors, especially impaired mobility, as well as cognitive impairment, or anything that is going to impair circulation to the affected area, like chronic edema or decreased perfusion. It's also known that poor nutritional status and poor functional status are associated with the increased risk of pressure ulcers. There is not great data for protein supplementation or vitamin C supplementation as specific ways of reducing the risk of pressure ulcers, although that has been studied. Rather, it's definitely very important to take a multidisciplinary approach to the care of a patient at risk for a pressure ulcer or who has a pressure ulcer, including nutrition, physical therapy, along with all the medical, surgical, and nursing teams. And of course, there are many environmental factors that contribute to the development of pressure ulcers, like any unrelieved pressure, friction, or shearing forces in an area, particularly where the soft tissue is thin, and controlling moisture, which can lead to skin irritation and skin breakdown, is also very important. So some strategies to reduce the risk of pressure injuries include mobilization, early and often, along with performing regular skin assessments and repositioning areas that are at risk of developing pressure injuries. Protective dressings and surfaces can also be helpful, along with strategies to reduce moisture provision in high moisture areas like the lower back and the groin. Optimizing nutritional status, again, through a holistic approach, not necessarily supplementation is important, and involving a multidisciplinary team of physicians, nurses, therapists, surgeons, where needed. So it can be challenging to diagnose pressure injury associated infections because, of course, many of the conditions that predispose someone to getting a pressure injury, like cognitive and functional impairment, may also mean that these residents will have trouble telling you when something is wrong. They may complain to you of worsening pain in the area, although that's also challenging because pressure injuries themselves are typically quite painful for a resident who has sensation. Confusion or fever can be symptoms of a pressure ulcer infection if you don't have another cause, like an infection somewhere else, or in the case of confusion, other causes like a change in medication, dehydration, constipation, for example. Some of the signs that you might see on exam include redness or induration of the skin surrounding the ulcer, new areas of necrosis, or any purulent drainage or bad smell coming from the wound bed. It's tempting, especially if there's pus, to want to send a surface wound culture, but in actuality, these are rarely helpful. Just because if you think about it, that is an area that is already contaminated with so many bacteria from the skin, colonizing the wound bed. Even if there is no true deeper infection present, a culture will always be positive. And the bacteria in the culture don't necessarily reflect the bacteria deeper in the soft tissues that are actually causing the infection. So this is not something we would typically recommend. And if you're worried that maybe this is a pressure ulcer infection that has progressed to osteomyelitis, it's just important to be aware that imaging studies like X-rays, MRIs, or tagged white blood cell scans can give you some additional information, but they cannot really make the diagnosis of osteomyelitis. I'll talk more about why that is complicated in a moment. Typically, if you have a true pressure ulcer infection, you're going to need to treat it with systemic antibiotics and not topical antibiotics. For treating this type of infection, oral antibiotics, especially empirically, are going to be equivalent to IV. Of course, it's different, if you know that the resident has a history of some sort of really resistant infection that needs IV. But in the majority of cases, you can use an oral antibiotic even to treat pressure ulcer associated osteo. And the duration of antibiotics needed to treat these types of infections is very unclear and very controversial. So it's controversial because the relationship between stage 4 pressure ulcers and osteomyelitis is not an area that is very well studied. So a recent meta-analysis found only 20 high-quality studies from 1975 to 2018, and none of them were randomized trials. But in multiple different case series, less than half of patients with stage 4 ulcers, even where there was exposed bone, actually had osteomyelitis on bone biopsy, which is the gold standard of diagnosis for osteomyelitis. And these studies also found that while MRI was very sensitive for the detection of osteomyelitis, compared to the gold standard of bone biopsy, it was very nonspecific, in some case series as low as 22%, because an MRI can't really distinguish between inflammation from an infection versus inflammation that is part of the typical bone remodeling that you would see when the bone's not covered by soft tissue. These studies found no correlation between the age of the ulcer and osteo. So just because an ulcer is old, it doesn't necessarily make osteomyelitis more likely. And interestingly, and also challengingly, there was not really a good correlation between systemic signs of infection like fever or elevated white blood cell count and inflammatory markers and osteomyelitis either. It was hypothesized that this was probably because the residents with these signs had infection of the soft tissue of the ulcer, but not the bone. And so this just kind of underscores that it's very difficult to distinguish between what is just an infection of the ulcer and what is an actual infection of the bone underneath, just based on lab tests or reported symptoms and signs. So the types of organisms that you're going to worry about with an ulcer-related or pressure ulcer-related infection are similar in some ways to cellulitis, in that staph, especially staph, but also strep are very common organisms. But these infections are much more likely to be polymicrobial, including gram-negative organisms. And if you think about it, it makes sense because these are typically going to be lower on the body, like the lower back or on the lower extremities. And so in these cases, empiric treatment with an agent that includes some gram-negative coverage, like amoxicillin clavulanate, or something like ceftriaxone, if the resident can't take oral antibiotics, would be reasonable. If the goal of treating the pressure ulcer is really cure, then the best chance of recovery comes from a combined medical and surgical approach. So surgical debridement and flap coverage is very much, or in the limited data we have, superior to treating with antibiotics alone. If you have a resident who is not a surgical candidate, which probably includes most residents who are prone to these types of infections, there is very little evidence that giving prolonged courses of antibiotics does anything to improve wound healing or to reduce the risk of future infections. Certainly, there's no evidence for treating longer than 6 weeks. And there's even some evidence that treating for 2 weeks rather than 4 to 6 weeks may lead to just as good outcomes with less risk of unwanted side effects like C. diff or drug-related allergies or drug-drug interactions. Let's finish up by going through a case of Betty. So this is an older woman who's transferring to your facility after a long ICU stay for pneumonia and decompensated heart failure. When you're looking through her chart, you see that she has some other medical conditions, most notably prior strokes that have led to some dementia and also hemiplegia severe right-sided weakness that leads her to be in a wheelchair most of the time. She also has prediabetes and doesn't take any medications for that. You get report that she has a stage 4 pressure ulcer over her sacrum. And when you're looking at the records from the hospital, you see that a couple of days before she was discharged, someone swabbed that ulcer. And the preliminary culture result did come back with normal skin flora, with some Pseudomonas, Staph aureus, and rare Proteus mirabilis. But you notice that she wasn't on antibiotics when they got that culture, and she's not on antibiotics now. So what do you want to do next for Betty? Do you want to contact the hospital to get the final culture results, including the antibiotic susceptibilities? Repeat the wound culture when you go see her? Go ahead and start her on vancomycin and Zosyn, which are probably going to cover those bacteria. Or do we want to make a decision after we assess her? Okay, so we have some votes for a go and assess, and we have some votes for get the culture results. Let's say that you do both. So you fax over your records request, and then you go to see her. So you check her vital signs, and her temperature is 98.6, heart rate of 84, blood pressure of 137/85 with a respiratory rate of 14. When you weigh her, you do calculate her BMI is 18. So she is underweight. She is oriented to herself only, but her grandson tells you that that is her baseline. She's very pleasant and chatty with you. And when you ask her about her back, she says that it hurts, but it's not so bad compared to the usual. When you turn her onto her side, you see that she has a 5 centimeter by 3 centimeter full thickness pressure ulcer with exposed bone of the sacrococcygeal spine. But the soft tissue around the bone is not edematous, it's not red. You don't notice any purulent drainage or any foul smell. So her grandson is very involved. You know, he's been on his phone looking up all the hospital records himself. And he saw that she had a positive wound culture before she left that no one is treating. So he tells you, you know, the last time she grew bacteria from her ulcer, her doctor put her on IV antibiotics for 6 weeks. So since it came back, shouldn't we start her on some IV antibiotics again now? So what would you want to say to Betty's grandson? That before we start treatment, we need to get the wound culture results, or that first we need to get an MRI to confirm whether she has osteomyelitis. Would you want to tell him that in this case, we can give her some oral antibiotics? They'll be just as good as IV. Or should we say, why don't we concentrate on improving her nutrition and protecting her skin? Okay, so we have a kind of a split vote. Vote for getting wound culture results, vote for getting an MRI, and a vote for just supportive care for now. So in this case, I would say that we don't have a lot of evidence that Betty actually has a pressure ulcer infection. She's not complaining of increased pain. The wound itself is not erythematous. There's no pus. And her vital signs look okay. She doesn't have a fever. She's hemodynamically stable, not septic. So this is a situation where I think it would be perfectly reasonable to treat her supportively, optimize her nutrition, take care of the wound, and monitor it closely before going down the route of working her up and treating her for a pressure ulcer-related infection. Remember, a positive wound culture in this situation is basically a given, because that open wound is an area where bacteria are naturally going to grow, even if they're not actually invading into the skin and causing, or invading into the soft tissue rather, and causing any damage. So just some take-home messages from our talk about pressure injuries. Important to note that these are very common, particularly in residents with limited mobility and poor functional status. Pressure injury prevention really requires a multidisciplinary approach from the medical team, the nursing team, the medical team, the nursing team, nutrition, physical therapists. And because of the nature of these injuries and the types of residents who are prone to get them, diagnosing a pressure ulcer associated infection can be very clinically challenging. In a resident who is clinically stable, and where the diagnosis is uncertain, there is not going to be any harm in taking a watchful waiting approach, trying to care for the ulcer as best as you can and monitoring them for any more obvious signs and symptoms of infection before you go down the route of diagnostic workup and starting them on antibiotics. It's important to keep in mind that just because the ulcer has chronically exposed bone, that does not necessarily mean that there is osteomyelitis there, in the absence of any other evidence of infection, like evidence of a soft tissue infection, or fever. And even when you do suspect that the resident does have chronic osteomyelitis, if they're not a candidate for surgical debridement and flap coverage, it's very likely that 14 days of antibiotics will lead to as good an outcome as treating with 4 to 6 weeks. The longer course is not more likely to lead to healing of the ulcer, or to prevent them from developing recurrent infections in the future. So I